We made a very deliberate effort to change healthcare access in New Orleans after the hurricane to one where the door that patients could most easily get in was one of primary care and prevention. We wanted to make sure that it was the best place for the best quality care that was affordable to everybody in the neighborhood. So we built a network of what's now about 100 primary care sites across our region. There are within that about 20 robust community health centers where people can go to get care, not just for physical health, like for diabetes, but also mental health and social services and other supports they need to be healthy. It was not a matter of revamping primary care for us in this community. We had to build it from scratch. We had not had a track record of ever doing that. We had been relying on hospitals and emergency rooms to support care for most people, especially for the uninsured, which is not a small number. Uninsured in our community is about 1 in 5 people. So we wanted to change that and give them the right place that they could go where they would be able to call it a medical home. It meant also that not just did we have to build the delivery model, but we had to build the bricks and mortar. We had to build the actual places of care. We've had to actually build a workforce, and we had to build our understanding about how to work together collaboratively as a community of providers to make sure everybody was supporting the patients in the way they needed. It was really critical to us as we built this new system after Hurricane Katrina that we built it with the right tools in place so that providers could provide the right care that they needed to for the patient at the right time. And so that for us meant to put into place electronic health records right away. Since these were new systems new clinics that were emerging, there was no reason to really go to paper. We went right to electronic health records, and even in our mental health providers. So about 85% of the system is using electronic health records. And when I say system, I mean it's really 20 organizations working together to deliver service, but they've all agreed on a same set of goals, and one of them is to use electronic health records, knowing that if a patient has to make a call to the clinic after hours or on the weekends, that information is available about the record and they can help that patient right then and there, knowing that if there is a disaster and patients have to evacuate, it's easier to get a handle on that patient's information, to know what their medication regimen is for their heart failure or whatever other ailments they may have. So hospitals are working with the clinic system as part of the continuum in many ways. So one of them is using the information available in the electronic health record to think broadly about quality of care for the whole population. So as patients are moving through the healthcare system with diabetes, with heart disease, with asthma, they get care at a variety of places. And so that information about their care needs to be shared. And all those providers working on that patient, whether a hospital or a clinic, need to have the same way to define diabetes, the same goals about quality of care for diabetes to make sure that everybody's getting what they need when they should. And so we have been working as a community to build up electronic health records at the point of care, not only in clinics, but also implementing in hospitals, and then sharing that through a health information exchange so that data moves with patients. I've been the Commissioner of Public Health now for a couple of years, and we have been working closely with the community of primary care clinics in particular for a couple of reasons. One is I came from that community. I ran health centers, and I remain as the president of a group called 504 HealthNet, which is the coalition of the community health providers. And that group works together on a regular basis around quality of care, access to care, information flow through information technology. And so I am a part of that system with them, whether it's thinking through how we can advance population health through their services and or how we can work together on critical issues that are important to the broader public's health. So, for example, emergency preparedness is an area that we are working on together. It's a place that not only are they a resource for us in the health department as clinicians to support services when needed, but they know these patients because they're theirs every day. They know who's most at risk in the event of power outage or high water or any other event. And so we are working together systematically to identify those folks using clinical information meaning those patients who are going to need the most help from us and the health department and the city government in the event of a disaster, but then also thinking through how every day we're working to build a more resilient population who's prepared for emergency, but really just prepared to have a better quality of life. And we think a lot in that sphere about our vulnerable populations, like the poor, the elderly, who need extra supports, and the clinics are just a really great partner and support in that, as are the hospitals, because they see those folks clinically, and we can help fill in some gaps with them in the other areas. That's a really interesting question that we haven't looked at recently, but I think that what I would say is we have gone from 0 to 100, essentially, of access to services in the community. We know that the services are being used. About 20% of our population is using outpatient services in this new safety net of healthcare centers, and there was really nothing there before. So if you think about 8 years ago, 200,000 people were not having access to care in those services. I think that's a pretty big jump for a city in an area whose population is only about 1 million. So we know that there's been a big jump in the number of services. We know that we have built back the rest of the continuum of care. What remains to be seen is what the outcomes will look like. If we'll be able to reduce unnecessary use of hospitals and ERs, improve the cost equation, and really improve quality and quality of life for our patients. But we're beginning to track that now, and we expect that the infrastructure we've built will lead to some much better outcomes for the population. Well, I always say that New Orleans is more like jazz than symphony. And by that I mean, in some communities there is an orchestra leader and first chair, but in our community we tend to riff off each other and make beautiful music in that way. And so there have been many leaders in this process, and this collaboration between the clinics, for example, of it being 20 different organizations. Yes, we have a 504 Health Net organization, and yes, there is a leader of that group, but we all make decisions in consensus, and that's the way we have moved forward as a community in the last 8 years. And I believe firmly that that is why it has stuck and why it is working, because we are making decisions that we all can buy into and that we all believe in, and so that we all own it, including patients in many circumstances. So the idea of a social movement is that it comes from the ground. It's got a grassroots feeling to it, where people identify a common enemy, an opportunity to make change and work in innovative ways across sectors in a very sustained way to redefine their culture, redefine their values and their priorities. And that's what's happened in New Orleans all across the board. In healthcare, certainly, we've shown that we can, with our sustained effort and our ability to be innovative and work together, decide that it's not good enough that we have poor quality and poor health outcomes, that we deserve better as a community. And so we've worked to change that equation, re-engineer it. But we've done that as a community in New Orleans through civic engagement and a common purpose in education and working on the criminal justice system and the levy system and a whole host of other areas where I think it's an exciting place to be and is a good model for other communities who want to make change. But really what we're doing here has happened at other times in other communities on grand scales. It's just that it's happened so quickly and so visibly after this catastrophe that we've gotten a lot of attention for it.